Okay, good afternoon, everybody. I'm sorry there is a bit of a technical problem. So our registrar is not able to present due to some technical unavoidable reasons. But I am delighted and I'm very happy to have Dr. Nirav Patel as our invited guest, and he is kindly agreed to give his talk without even our registrar giving his talk. And I knew Dr. Patel for about 6 years or so. And in fact, I probably was one of his examiners when he did his oral exams for his fellowship. And I'm so proud to say what Dr. Patel has achieved so far is absolutely remarkable. And we just need to remember that we have such young surgeons in our country who are doing very well. And I just had to project this, this image of his beautifully made business card, which is so attractive that I thought I should project it here. And Dr. Patel is currently a consultant pediatric surgeon at Krisani Baragwanath Hospital in Johannesburg, affiliated to Wits University. He, I believe, also has some private practice, but in his state practice and everywhere, he is quite keen about surgical education, and his fields of interest, in addition to general pediatric surgery, are hepatobiliary pancreatic surgery and minimally invasive surgery. And Nirav, as a person, has lots of dimensions. I don't know whether you people noticed that he also has not only bachelor, but master's in arts before he decided to medicine. And that really gives a very different perspective to any doctor to have done masters in arts. So Neeraj is one of those rare breed of doctors. And I was so happy and proud to know that after his community service, Neeraj has offered his services to MSF in Somaliland. And he's also one of the directors of Surgeons for Little Lives, which is a not-for-profit organization, something very similar to our Yabantwana for the Children's Trust, which we have formulated in East London. And this is in Gauteng and in Greater Johannesburg area. He obviously is a proud Witsy throughout, from undergraduates till fellowship and consultant position, and also proudly South African. He loves to travel, and he's a perfect family man. And this, I'm sure many of you will recognize this beautiful photo of Tiger Monastery in Nepal, where Neeraj has already visited. So he makes me actually jealous of him. Neeraj, very, very happy to have you. And please, I will stop sharing my screen, and you can share your screen, and you can share your thoughts, and we have plenty of time. So please do not cut short any part of your presentation.
Thanks very much, Prof. You guys all able to see my screen?
Yes.
Okay. Okay, so yeah, I didn't manage to get a look at Dr. Jula's presentation before he presented, but today I'll be presenting on pancreatic tumors and PPHI, or persistent hyperinsulinemic hypoglycemia of infancy, or congenital hyperinsulinism. Thank you very much, Prof, for that very nice and kind introduction, and congratulations to your team and yourself in East London for hosting these pretty high quality and consistent seminars for us to all learn from. So again, today's topic is divided into two parts: pancreatic tumors and PPHI. They're quite diverse, but there are some similarities in terms of the surgical management of the conditions, and the implications of such management for the patients. And I'll try and draw some commonalities there. So beginning with pancreatic tumors, they're exceedingly rare. I mean, exceedingly rare. In the United States, the malignant tumors of the pancreas have an incidence of about 0.46 per 1 million population. So just to put that into perspective, what that number actually means is that in a country of 350 million individuals, in a 30-year cohort between 1976 and 2004, 1974 and 2004, there were only 120 cases of pancreatic malignancy. We don't have any national South African data that I am aware of, but at Barra, Dr. Harrison and Dr. Mshunje did a review of all pediatric oncological cases between 2007 and 2016. And what they found was that we treated 330 solid organ tumors of interest that were malignant and 57 that were benign. So we had one pancreatic tumor in the malignant group and one pancreatic tumor in the benign group. The pancreatic tumor in the malignant group was located in the head of the pancreas, and a patient underwent Whipple's pancreaticoduodenectomy. The mass that was found in the benign group actually turned out to be hemangioendothelioma, and the patient was treated medically. So basically, pancreatic tumors can be classified as either endocrine or exocrine, with exocrine being further classified as epithelial or non-epithelial. The main risk factors for pancreatic tumors or malignant pancreatic tumors in children are female gender and age. So your age greater than 10 and female gender. And this is a table from another large case series. You see that the numbers in patients over the age of 10 are much higher, and the ratio of males to females is nearly 2:1, or females to males is nearly 2:1. There are certain types of pancreatic tumors that are associated with congenital abnormalities, such as Beckwith-Wiedemann syndrome and multiple endocrine neoplasia, namely pancreaticoblastoma and insulinoma. But by and large, the main risk factors are gender and age. Amongst children, there's a clear bimodal distribution, you would say. That's the correct terminology. Children under the age of 10 generally suffer from pancreaticoblastoma, and children over the age of 10 generally suffer from solid pseudopapillary neoplasms and endocrine tumors, most particularly insulinomas. So pancreatic tumors are actually a heterogeneous group of tumors. There's a very wide range of diagnoses that the tumor may be, and they may be in very different locations within the pancreas. But overwhelmingly, the majority of tumors are pseudopapillary and solid pseudopapillary neoplasms. So this is a table that came out of a systematic review of all the literature, English literature on pediatric pancreatic tumors between 1976 and 2018. And in that review, they were able to document 489 different cases of pancreatic tumors in children. And a full 300 or 60% of them were solid pseudopapillary tumors, with the remainder being split up between pancreaticoblastomas and neuroendocrine tumors in the main. Just to demonstrate the heterogeneity of the types of tumors that you can get, we know that the majority of the tumors are solid pseudopapillary neoplasms. This is another table from a paper published in the United States, demonstrating the different types of malignancies they found in the head of the pancreas. And I mean, it's a very, very wide range of different malignancies. Children with pancreatic tumors don't present in the same way that adults would. Children generally present with abdominal pain and a mass. They may also present with loss of weight and then symptoms of compression, early satiety or constipation. Tumors that are secretory will obviously present slightly differently, and the majority of those would be insulinomas. Children would present with symptoms of hyperinsulinism. This is important because children don't present like adults, so they won't necessarily present with painless obstructive jaundice or anything like that. So it's important to keep in mind that abdominal pain can be nothing and can be something that's extremely serious in children, and not to always maintain a very high level of suspicion. The workup for these types of tumors is basically dependent upon imaging, and in some cases, tumor markers do play a role. The relevant tumor markers are alpha-fetal protein, CA19-9 and CA125. But essentially, the workup of these patients for isolated or non-metastatic lesions involves your preoperative imaging. Most centers advocate for starting with an abdominal ultrasound and then moving on to either a high-resolution contrasted CT scan or an MRI. The choice between the two really depends on the institution. The benefit of the MRI is that it does decrease the child's radiation exposure. There may be a role for endoscopic ultrasound. This is particularly for patients that don't have pathognomonic features on either high-resolution contrasted CT scan or an MRI for the type of tumor that you're dealing with. So endoscopic ultrasound is useful if it's available at your institution for performing a biopsy, and sometimes for also localizing a tumor. A dual modality is always preferable to a single modality, but the dual modality really implies using an ultrasound and either a CT scan or an MRI, not a CT scan and an MRI together. Surgical resection is the mainstay of therapy, and this is so because of the increased survival and decreased recurrence associated with surgical therapy. The goals of surgical treatment are essentially complete surgical resection with a minimization of complications. Biopsy may be necessary, particularly when imaging characteristics are not pathognomonic for the particular malignancy. So if there's any suspicion that it's not a solid cerebropapillary neoplasm, it may be necessary to perform a biopsy in order to decide whether the patient should receive neoadjuvant or adjuvant chemotherapy. It's also useful in patients whose tumors are deemed irresectable to decide whether the patient would benefit from neoadjuvant chemotherapy and what is the appropriate therapy to give. The biopsy can be performed open, percutaneously, or endoscopically. Endoscopically being the least invasive, but requiring specialized equipment and a specialized set of skills. So once you've gotten over the need for performing a biopsy and neoadjuvant therapy, when you approach pancreatic tumors, there's a few questions that need to be answered. Is it appropriate to approach the tumor open or laparoscopically? Where is the tumor located? So is it in the head or the neck, the tail or the body? For tumors that are located in the tail, the tail or the body, is spleen preserving surgery safe? And for tumors that are located in the head and the neck, is there a need for vascular reconstruction? And this refers particularly to the portal vein and then to the superior mesenteric artery, the celiac axis, and the hepatic artery. If you try and answer those few questions, then it would give you a good approach to how to approach these tumors. This is again from that same systematic review that I mentioned by Miolanis, and it just illustrates that about half of all pancreatic tumors are found in the head and the neck. About 1/3 are found in the tail, and about 20% are found in the body. So it's actually very difficult to precisely define the different parts of the pancreas. It's not well defined within surgical textbooks, and it's not well defined within radiological textbooks. But just as a rule of thumb, you could think of everything to the left of the inferior mesenteric artery as the tail. Anything between the inferior mesenteric vein, my apologies. Anything between the superior mesenteric vein and the inferior mesenteric vein as the body, and anything to the right of the superior mesenteric vein as the head and the neck. So the type of surgical resection that you perform really depends on the location of the tumor. And there are a few different options that can be considered. The first one is a Whipple's pancreaticoduodenectomy for masses that are in the head and the neck of the pancreas. The second one is a distal pancreatectomy or a spleen-sparing distal pancreatectomy for masses that are in the body or the tail. And then there's the possibility of a central pancreatectomy or enucleation, and I'll discuss each one of them. So within the literature, there are a few case series of relatively small number of patients spanning multiple decades of Whipple's pancreaticoduodenectomy in children. the pathology necessitating Whipple's procedure in these children is actually quite heterogeneous. And I could find a report of a child as young as 4 months old undergoing this procedure. Because there's because there's a lot of trainees and maybe not everyone has spent a lot of time in general surgery, I think it's important to just illustrate what the Whipple's actually is. So essentially it's a resection of the antrum, the pylorus, and the duodenum, and a reconstruction by a pancreaticojejunostomy, a gastrojejunostomy, and a hepaticojejunostomy. I think that's quite important to know, because we often say Whipple's, but we don't necessarily know what it means. So this is an image of actually one of the children at Baba who underwent pancreaticoduodenectomy for a head of pancreas mass. And you can see the mass here in the coronal view. And in the sagittal, you can see quite nicely how big the mass is and how it's splayed the celiac axis and the superior mesenteric artery. So essentially, you get two types of Whipple's procedures. You get a pylorus preserving and a standard procedure. In children, the pylorus preserving procedure is reported to be associated with higher rates of complication. These complications being delayed gastric emptying and tumor recurrence. I was unable to find any description of a laparoscopic pancreaticoduodenectomy in any of the pediatric patients who underwent this procedure for a head of pancreas mass. It's also important to note that there's two ways in which to do the pancreaticojejunostomy, and this really depends on the size of the duct that you're trying to anastomose to. So if the duct is very dilated, you can do a duct to mucosa anastomosis. But in very young children, this may not be possible, and you may need to do the anastomosis to the capsule of the pancreas. The complication rates for Whipple's procedure in children are reported to be quite low. And this is probably a function of the fact that children have predominantly solid pseudopapillary neoplasms, which are of very low malignant potential, and because they have good planes. The most common complications that are described are pancreatic fistulae, pancreatic fistula, delayed gastric emptying, tumor recurrence, and pancreatic exocrine and endocrine insufficiency. In some case series, I found reports of up to 60% of children suffering from exocrine and endocrine insufficiency after undergoing pancreaticoduodenectomy. The younger you are when the procedure is performed and the more mass of the pancreas that is removed, the more likely it is that you will develop endocrine insufficiency as you grow. Recurrence rates were reported to be up to 40% with a mortality of up to 50% for pancreaticoduodenectomy in children, but really this is actually just a function of the tumor histology. So your recurrence rates and your prognosis is worse with non-solid pseudopapillary neoplasms and where there's vascular involvement. But overall, from my reading, my understanding is that this is a well-tolerated procedure in young children. So turning to distal pancreatectomy, like I mentioned, there are two different types. There's a spleen preserving and a non-spleen preserving distal pancreatectomy. From my reading and understanding, the laparoscopic approach is the gold standard, and where possible, histology permitting, splenic preservation is the way to go. It has a relatively low complication rate, this particular procedure, and it's very rare for patients to develop exocrine or endocrine insufficiency. From the reading that I did, I was not able to find any report of a laparoscopic spleen-sparing distal pancreatectomy where splenic vein reconstruction was required, but this is something that should be considered. Prof did ask me for videos of pancreatectomy, whatever form we had available to us, but unfortunately we don't have a very big case series and we don't often take videos of our operations. So I have provided a link for a nice video that I found on YouTube for a laparoscopic spleen preserving distal pancreatectomy that people can look at when they have some time. So enucleation and central pancreatectomy are very well described in the literature. My understanding is that they should be only applied to very well localized tumors of low or no malignant potential. Intraoperatively, it would be useful to perform an ultrasound to check for ductal involvement. This is particularly important in order to prevent a pancreatic fistula. I think enucleation in the head of the pancreas, although it is described, is potentially a very tricky procedure because it's probably very difficult to obtain a negative margin in head of pancreas masses due to the proximity to major ductal structures, the pancreatic and common bile ducts, and major vascular structures. The advantage of enucleation and central pancreatectomy is simply that they're pancreas preserving and you don't run into the problems of exocrine and endocrine insufficiency that you may with other forms of pancreatectomy. But that comes at the expense of possible tumor recurrence and developing a pancreatic fistula. So again, this table comes from the systematic review that I told you about. And you can see of all of the 489 cases, only about 10% were done, only about 10% underwent central pancreatectomy, and only about 9% underwent tumor enucleation. Chemotherapy and radiation do have a role to play, both as neoadjuvant and as adjuvant therapy in the management of pancreatic tumors, but they're not common in the management of the most common pancreatic tumor, which is a solid pseudopapillary neoplasm. For all other endocrine, epithelial, and non-epithelial exocrine tumors, they are routine. So this is a table depicting our experience at Chris Hani and in private since 2011. We had 5 cases of pancreatic tumors. 4 of them were in girls. All of them were in the head of the pancreas. We had 3 solid pseudopapillary neoplasms, 1 hemangioendothelioma, and 1 pancreaticoblastoma. 4 patients underwent a proposed pancreaticoduodenectomy, with 2 requiring a portal vein reconstruction that didn't require a graft. To my knowledge, all patients were alive and well at last follow-up, with 2 requiring revisions of the hepaticojejunostomies. The 1 patient was managed by interventional radiology. The other patient required a surgical revision of the hepaticojejunostomies. So even in our center, I mean, it's a very limited experience over quite a long period of time. So in summary, I would say that pancreatic tumors are extremely, extremely rare. Imaging is fundamental to the planning of the management of these patients. Surgery is a fundamental, or is probably the most critical component of management, and the procedure that you perform is really determined by the tumor location and the likely histology. Pancreatectomy, in whatever form, is safe in children. Adjuvant and neoadjuvant therapy may be necessary in the management of these patients, depending on the histology. In our series at Baragwanath Hospital and in private, all of these tumors have been managed by pediatric surgeons. Whether the pediatric surgeon should be performing these cases, given their rarity and our relative inexperience with this type of anatomy and this type of procedure, is a matter of debate. I think it would really depend on the particular skills that you have available at your institution. Given that these tumors are so rare, I would like to hear what people think about the need to centralize care for these tumors within particular centers in our country. I'd be quite interested to hear what people think about that. So I anticipated that I'd follow Dr. Jula, so I didn't really want to talk too much about PPHI, so I'll just keep it quite brief, also being mindful that I don't want to run over my time. PPHI for me is a heterogeneous disease. So genetically it's a heterogeneous disease, and histologically it's a heterogeneous disease. Although all of the patients will present in essentially the same way. These patients will usually present as neonates with symptoms of hypoglycemia. And the goal of the biochemical workup is essentially to show that they have an abnormal level of insulin relative to their blood glucose level. This is different from insulinomas, where patients would have an absolutely high level of insulin. The backbone of therapy of PPHI is to treat patients with medical therapy, and this is in the form of continuous feeds or a dextrose infusion and various different drugs, including diazoxide, a somatostatin analog, glucagon, and sirolimus. I think about 5 or 6 years ago, sirolimus was touted as the new wonder drug in the management of congenital hyperinsulinism. And this was because it was shown to have worked in patients with insulinemia. And the thinking is that it decreases islet cell production of insulin and increases peripheral resistance to insulin. It was touted as a drug that could be used to avoid surgery in children with diffuse PHI. But since then, there have been multiple studies that demonstrate that the effect of sirolimus is actually variable, and it has a very high, very wide side effect profile, with some of the side effects, in fact, being quite serious. Unfortunately, it's not the wonder drug that we initially thought it would be. So given that there are different forms of PHI genetically, and that because of this, some patients respond better to medical therapy than other patients, it may be necessary for some patients to undergo surgery. And essentially, the purpose of the surgical workup is to differentiate between focal and diffuse disease, because it will be this differentiation that determines the type of surgical resection that is required for the patient. Previously, pancreatic venous sampling was the gold standard in determining the differentiation and trying to differentiate between focal and diffuse disease. I think this has changed quite substantially with the advent of this 18-fluoro-FL-DOPA PET-CT scan, which is now the gold standard for determining the for differentiating between focal and diffuse disease. The management of patients that are not responsive to medical therapy, so patients that are not responsive to diazoxide, is always pancreatectomy in whatever form. If it's for focal disease, then it's a focal resection. If it's for diffuse disease, then it's near total or subtotal to near total pancreatectomy. There's no major reconstruction involved, and it's very important to consider your preoperative imaging and potentially make use of intraoperative ultrasound, frozen sections, loop magnification, and palpation of the pancreas to help you to decide whether you have achieved this acceptable resection or not. Laparoscopy is very well described, and this is particularly for well-localized focal lesions. So just to end on PHI, for those patients that respond to medical therapy, surgery is not indicated. For patients that do require surgery, the important things to do are to differentiate between focal and diffuse disease. In patients that have diffuse disease and undergo subtotal or near total pancreatectomy, pancreatic insufficiency is extremely common, affecting up to 60% of patients. This is both with respect to its exocrine and endocrine function. I think that this is a very difficult condition to manage, in spite of having a multidisciplinary team approach. And I would like to put it to everyone. In a patient who has diffuse disease, is it preferable to try and manage the patient's hypoglycemia medically with the risk of recurrent hypoglycemic events? Or is it better to take a more aggressive approach, perform surgery earlier, and then potentially leave the patient at risk of hyperglycemia, either in the immediate postoperative period or later as they grow? I'm not sure what the answer is, but I think that it's an important discussion to have with the parents of these patients. So in Joburg, I did some digging and found about 11 patients. 2 of them were missing data. 3 had a glutamate dehydrogenase abnormality, so they responded to medical therapy, and 6 underwent surgery. Of the 6 that underwent surgery, 3 initially underwent a 95% pancreatectomy and 3 underwent a 90% pancreatectomy. The 3 that underwent a 95% pancreatectomy required further resection, all 3 of them. Of the 6 patients that underwent some form of pancreatectomy, 3 or half are now currently insulin dependent and all have pancreatic exocrine insufficiency. I had a chat with the pediatric endocrinologist at Barra, and they actually had no cases at Barra that they could recall. And in the textbook, the prevalence of or incidence of PPHI is reported to be 1 in every 50,000 live births. So I would like to ask all of you from all of your different institutions if you have any experience with these patients in the public sector, and if you don't, then where are they? So I'd like to thank Dr. Grieve, Prof. Loveland, Dr. Connor, and Dr. Boshoff for helping me collect the data and providing some images. And for any of the trainees, I have a little quiz, and when I see you, I'll give you a Surgeons for Little Lives t-shirt for anyone that can answer the question. If anyone can tell me what is the origin of the name rapamycin? Not for the consultants, just for the trainees.
Nirav, thank you very much. That was really an excellent, relatively simplified and very practical talk on pancreatic tumors, which is quite a rare but an important topic, and PPHI, which I think is also quite a difficult topic and which we do not see. So I will certainly invite comments from our colleagues who are attending, but just a couple of very brief comments is I think, Nirav, we are missing all those patients in the public sector. They are just getting hypoglycemic, some of them getting neurologically impaired, and they are just not getting diagnosed enough workup for us to find either an insulinoma or PPHI. That's number one. And secondly, I think you asked about whether we should centralize the management of pancreatic tumors in children. I would certainly support that concept. I don't know what my colleagues in centers bigger than East London would think, but I think it is time that we start centralizing care of such extremely rare conditions. But that's, I think, something for us to discuss as South African Association of Pediatric Surgeons to take it forward. So Nirav, thank you for your talk. I would like to invite Dr. Derek Harrison, who is also one of the consultant pediatric surgeons at Baragwana, and also partly in private practice, if I'm correct, and has keen interest in pediatric surgical oncology. So Derek, please give your comments, your advice. You'll need to unmute yourself, Derek.
Hi, Milind, thanks. So, yeah, just going to your persistent hypoglycemias, we have seen them in the public sector, but not at Barra. They've been, the times I did my rotations at Charlotte, we had a couple there. So we have done a couple there. But yeah, for some unknown reason, I don't know why there haven't been any at Barra. And then, yeah, your pancreatic tumors, yes, they certainly are rare. They also, you know, some of the generals, well, the HPB unit are doing kids above 10 at Baragwanath. So they have, in fact, they did 2 were done just recently by the adult HPB guys. And they both were solid pseudopapillary tumors. In fact, one was a massive one and quite an unfortunate outcome at the end. But the other one, which I was involved in, had quite a good outcome. So that was good. But of course, they should be centralized. I mean, they're just so rare, and not everyone knows how to do the surgery. And then, of course, if you're not familiar with it, then you should, you know, work together as a team with the adult guys. But yeah, it's actually was a nice presentation by Nirav, so that's well done. It was very good. Thanks.
Yeah, thank you, Derek. I fully agree with you. I mean, if you have to do any pancreatic surgery in a child, you rather do it with, if you have experienced hepatobiliary surgeon or general surgeon, you take one of those colleagues with you, because we pediatric surgeons, we really do not do much pancreatic surgery. So thank you, Derek. I saw Dr. Charles Calapina was here, but I think he has exited the meeting. I'll now invite Professor Hadley to give his comments. Prof.
Hi, Milan. Thank you very much. Dr. Patel, thank you very much indeed. It was a lovely presentation. The questions you've raised, yes, pancreatic tumours are rare. I mean, in 30 years at King Edward, I saw one, which we resected in the company of the adult hepatobiliary guys. You're quite right. For each individual surgeon, personal experience is very low. In terms of centralisation, if we were a much smaller country, yes, that would be a good plan. I mean, centralisation works very well in places like the Netherlands, but you know, the disruption to the family of sending people from Durban to Cape Town or to Johannesburg for liver transplantation has shown us that the ease of centralisation is not as easy in this country as it would be in a smaller or European or elsewhere country. So it may be idealistic to centralise, but in practical terms, I think it's a lot more difficult than we think. In terms of hypoglycemia, you can deal with the complications of surgery, the need for insulin replacement, but you can't deal with an adult brain. Once the brain has gone, then there's nothing you can do about it. So particularly perhaps in the public sector, where monitoring might not be quite as complete and sophisticated as it would be in the private sector, we've always been very aggressive in terms of prescribing surgery for these patients. And I think really in our circumstances, early surgery is what we should all be aiming for. But I thought there was a fabulous presentation. Thank you very much indeed.
Thanks for that. Yeah, so I actually agree with you. I think it's very easy to say things like centralize and all of these things, but I mean, ultimately we're dealing with the patient, and the patient comes with the family because we are pediatric surgeons. And it's very important to think about the impact of your management on the patient rather than just technically being able to do a good job. So I do agree with you in that regard, Prof. Hadley. And also with respect to the PPHI question, I actually agree with you as well. I think it's easier to manage a patient's hyperglycemia than to be left with a patient that is hypoglycemic and now has to live as an adult with the effects of repeated episodes of hypoglycemia on their brain.
Yeah. Thank you, Prof. Hadley, and thank you, Nirav, for stressing and emphasizing that. I think just on, I see there's one pediatrician colleague from Queenstown, Dr. Sihele, who is attending, which I'm very glad about. And probably a message for her, but also mainly for our junior team members, that hypoglycemia is deadly, especially in newborns and infants. It's really very serious. If it doesn't kill you, it kills the quality of your life, because you can become neurologically so severely damaged that you may not be able to function. So as Nirav has said, as Dr. Harrison has said, and as Prof. Hadley has said, that it is probably relatively easier to treat hyperglycemia by adjusting the insulin dosages rather than managing the serious bad effects of attacks of hypoglycemia in a newborn, because a patient was just not offered surgical treatment and was continued conservative management. But Nirav, thank you for showing those different types and which ones can actually be managed completely medically and which ones need surgery, and also clarifying which ones need localized surgery, which ones need generalized, like near total or total subtotal pancreatectomy, etc. So all very useful information. So I think, Nirav, we are coming to the end of the meeting. So I'll just ask you to give us a take-home message from this today's meeting.
Okay, so I think from me, if we're reading about this, the mainstay of therapy for both of these conditions is ultimately surgery. In pancreatic tumors, probably that surgery should be done with the general surgeons, especially in centers where you don't necessarily have an individual pediatric surgeon with familiarity with that area and the ability to perform potentially complex vascular reconstructions.
Okay, Nirav, thank you very much. And with your permission, I will share the recording of our meeting with our colleagues in the rest of the country and also on the PPHI WhatsApp group. So, Nirav, thank you again. I see there was one hand raised.
Yeah, it was me.
Yes, yes, Prof. Yes. Yes, Prof.
It's just, I'd just like to say that it's so unusual for a speaker to agree with me on 2 consecutive points. that I'm actually going to seek a copy of this recording. And thank enormously for doing so. Just like to also wishes.
But Prof, as much as I know Nirav, he's a very sincere and humble young pediatric surgeon. So that's probably the reason why he has agreed with you on 2 points in one lecture.
Oh, now you've deflated my balloon.
But thank you, Nirav. Thank you, Prof. Hadley, Derek, and all the attendees. And I'm sorry that there was a problem and our registrar couldn't or didn't present, but Dr. Patel had such an excellent top quality practical presentation that we really didn't miss the presentation from our junior. So next week, there will be a talk by Dr. Neha Gautam, our medical officer, about transitional care in pediatric surgery. And I'm almost certain that Professor Sherif Emile from Montreal, Canada, will be our invited guest for that talk. So we will see most of you and many more. Sorry, my apologies. I need to ask Dr. Yashoda Manikchand for her comments. I saw her, but Yashoda, my apologies. Please give your comments. Any comments, any questions?
Oh, thanks, Prof. But it's okay. My comments would be redundant because I think everyone has covered what I would have said, especially what you said about the hypoglycemia in the newborn being an emergency because of the long-term neurological damage. And I have to agree with Prof. Hadley on both those points too. And that has nothing to do with the fact that he trained me. And thank you, Nirav. It was a great presentation.
Okay, Yashoda. Thank you all and have a good evening, and we'll see you next week, Tuesday at the same time. Bye-bye now.